Okay, week 8, very, very busy week. And then on top of it, it is Thanksgiving. So it's going to be busy all around. I do hope that you do have time to celebrate Thanksgiving in your way. Friends and family, I think, are the best. I love Thanksgiving. I think it makes me realize that I'm grateful for so many things. And the one thing I did teach my children is being a nurse. I usually worked Thanksgiving. And you're going to say, why would I do that? Well, I worked Thanksgiving because I wanted to teach my children Thanksgiving isn't a Thursday in November. It's every day when you have a roof over your house and you have food to eat and you're with family. So that's what I taught my children, because nurse, you're going to have to work Thanksgivings. And you're like, gee, I missed it. No, you didn't, because we have a lot of things to be grateful for every single day. So that's my little Thanksgiving thing that I'll say. Week 8, a lot of things that you have due. Number 1, there is that pediatric assessment. What do I require from that? It's 3 parts. Number 1, choose a topic, send me a message so I can approve it. I don't want 28 PowerPoints and projects on autism or on asthma. That seems to be pretty well picked. So please shoot me an email or a message so I can okay what you want to do, okay? There is a bunch of suggestions on Module 8, so you could choose from. These are more of congenital syndromes, but maybe you knew somebody with something. Try to pick something near and dear to you, something that you learned from. It makes it more fun and it makes the time pass better if you're learning about something. Your kid, your sister's kid, your neighbor, your aunt, your uncle, somebody you knew in school, something. And it does make it go. On the assessment portion, make sure you put what your diagnosis is. So for instance, if you chose asthma, you're looking at respiratory, tell me what an asthma child would sound like if they're having an asthma attack, okay? That's what I want to see. And do not put within normal limits for like cardiovascular. They have a heart. Tell me what a heart sounds like, okay? That's what I want to hear there, not within normal. The little bit of 250-word APA paper, just describe the diagnosis, okay? And that's very brief. And then the teaching portion could be a brochure, PowerPoint, 5 or 6 slides. I don't need anything crazy. Or it could be a picture board. Just make sure you put a reference on that. Reference on your APA paper, a reference on your teaching. I think if you can teach a diagnosis, you understand it. So that's the reinforcement for you to think, how do I teach? I'm going to caution you, it goes through a plagiar checker. I've seen many students use somebody else's work and try to turn it in. It's happened. I'm just letting you know, change the words up, okay? Make it look different to me. I mean, I know you guys like shortcuts. I get it. Are you going to learn from that? Not as much, but please do not plagiarize. It'll come in at 99% plagiarism. And I don't want that, so that I'll send it back. Another thing, as soon as you're done with it, turn it in. Go right through the module. I will check it as soon as I see them. Give you comments if you want to increase your grade so that you can get the best grade possible. It is 6% of your subjective grade. It is a lot. So you can turn it in 2 or 3 times, as long as we get it in by Sunday. And even over this weekend, I'll be checking it for you, just so that you can get your best grade as you possibly can, okay? So this week, that's the first thing that's due. You have NCLEX questions, diabetes is open, and you have the pediatric assignment exam. Make sure that your calculate with confidence is in, and it has to be in by Sunday to get your full credit for that. Some of you didn't, so I sent you a message, put a 0 in so that you know, please just get it done, all right? So don't worry, you're not going to get a 0. You just turn it in and it'll be okay. Bayola, I love that little GIF on your, your screen. I'd never seen a moving one before. So let's start with the PowerPoint, and there are 54 Kahoots. So this is a full week. It's a lot of stuff that works with GI and GU, okay? And there are differences between adults and children. Probably the biggest area that you'll see those differences. So urinary tract infections. This is one of the most common conditions children get. A lot of it has to do with what? Bubble baths, right? Wearing tight little tights, you know, and these causes these children to get urinary tract infections. Plus, they're learning how to potty train. Actually, constipation can cause a child to have urinary tract infections. So keeping their bowels moving does a lot better for that. And then circumcised boys are better than uncircumcised. The reason is there between the foreskin and the penis, it gets this little white cheese called schmegma. And it's like a petri dish for bacteria. And if the mother don't pull it back every day and clean it, it can cause bacteria to go down the urethra and urinary tract infections. So how do we know a kid has urinary tract infections? I mean, you might see them rubbing themselves, you know, moving back and forth, going to the bathroom a lot, or you might see that they're incontinence. And if they don't flush really quick, or if they urinate in their underwear, then we could smell it. And we could see foul smelling needs to be investigated. So parents, especially during this potty training time, should be looking for this because it is that common. And making sure that they wash their hands. They know how to go front to back. Adolescents, they have said that urinary tract infections are due to having sex and then not urinating right after. They say the incidence of urinary tract infections on an adolescent goes down if after sexual intercourse you urinate. So that is something we could teach our adolescents. So how do we evaluate it? Well, you're saying, well, they're babies. What do we do? The most accurate type of urine specimen on an infant and young children is catheterized specimen. And you're going to say, but ooh, that hurts. Well, premature babies are too small, but a normal newborn, we could do a catheter. And it doesn't hurt, it's uncomfortable. They're more upset that they're being sort of held down. But we clean it good, get the catheter in, get a urine specimen, and now one time we can get what the culture says and what antibiotics should be given. They don't have immune system when they're small, right? We can't have them being repeated urinary tract infections and changing antibiotics. We could do it one time. And that is our goal and why we do it that way. So we get our urine culture sensitivity. An older kid, yeah, we'll do a clean catch unless they're frequent urinary tract infections. Now, premature children, the catheter's too big. It's an 8 French. It's not going to work. So what they do is a suprapubic aspiration. And what is that? Well, right above the suprapubic bone, they clean. They'll take a needle and go directly in the abdomen. And that's where the bladder is. And they'll pull out half a cc. It's about all they need. And now that is a really good, clean specimen because premature infants have no immune system. And if they have a fever or showing signs of sepsis, they do full septic workup, including a suprapubic aspiration for their urine. They could do kidney taps. We could put in catheters, do washouts, look at what's in there, ultrasounds to see if anything's structural. As they're getting older, we do something called a voiding cystourethropy. And it's an outpatient procedure where they use a Foley catheter and they look for reflux and how bad reflux from the vesicle up the ureters, vesicle being the bladder, going up. I mean, the sphincters aren't tight enough to keep it down. And as they get older, they go into the IVPs, more looking for stones, and then renal scans. So renal biopsies sometimes have to be done. whether it's a pyelonephritis that's non-resistant, you can't clean it up, so we need a specimen right from the kidney. Now, renal biopsy and cardiac calves, the treatment's basically the same postoperatively. So we're looking for the dressing in a cardiac calf in the groin for bleeding. Well, we're also going to have a pressure dressing to where the kidney biopsy was, looking for what? Well, bleeding could be too, but urine dripping out. So that's telling us something's going on with that kidney. And of course, we'll be measuring intake and output, making sure the bladder's still going. But again, we're going to check that dressing. We're going to take vital signs, bed rest 24 hours. And we're going to be checking the abdomen because maybe it's leaking urine inside the abdomen. So we're going to see if there's any tenderness there. I mean, infants, it's hard to find that kidney. They do ultrasound and look for it as they aspirate it, but sometimes it is more of an incision. Now, most of the time, stuff like this they'll do under some sort of sedation because a kid's not going to sit there, especially a 2 or 3-year-old. So they'll give some sedation for it. Now, I've been mentioning this obstructive uropathy, something happening with the flow of the urine. You know, it could cause hydronephrosis. You know, your ureters could be obstructed, you know, and then you go from the vesicle bladder, it's refluxing up into the ureters or up into the kidneys, called hydronephrosis. So depending on where it is, would be what the name is. So if it's the obstruction is in the bladder going, flow going back up, it's the vesicle ureter type of obstruction. Now, nephrotic syndrome, I was going to say this 3 times, has nothing to do with renal failure. This is not renal failure. Nephrotic syndrome is when the kidneys don't like protein and just get rid of it for whatever reason. So instead of holding on to protein, it's getting lost. Well, where is protein held? It's in your blood, right? We know that we need protein for giving medications because medications will jump on the protein or the albumin, whatever you want to call it, and we can monitor blood levels that way. So this creates the problem of we need lower doses because it's going to be a lot of free drug in that blood. So protein's going to come out, proteinuria, hypoalbuminemia, which is in the blood, there's no protein or albumin. And then that causes tissues to get full of fluid because it's trying to equalize. So you don't have enough, it's all liquid inside, so it's pushing the fluids out interstitially. So you'll see edema. A lot of these kids have big puffy face and puffy eyes that you see. Varies and lips, you'll see the face puffed up. Usually it's what you see with a kid who's in a crisis with nephrotic syndrome. And again, it's a massive loss of protein. Your kidneys are working, but protein is lost. Now, managing these children, they're immunosuppressed. These kids are at a high risk for infection. Now, their mouths are swollen, their tongues are swollen, it hurts to eat, so their appetite goes down. So if we're having all this swelling, no matter what the cause, what do you think we need to do? We need to decrease salt intake and fluid restriction. And we're going to be given something to get rid of this extra fluid, right? These children are basically placed for the anti-inflammatory they put on steroids to get this swelling to come down now. And this is lifelong. This isn't something that once and done. This is a lifelong situation. So family needs to know about these children and the salt and the fluids. And again, of course, always try to treat them as normal as we possibly can. So with all this proteins coming out, we have all of this edema. We need to prevent infections. And again, how do we manage this swelling, any swelling? Well, with the diet, decrease salt, decrease fluids, and we'll be monitoring that with strict I&O daily weights. Anything that has to do with fluid, those are the things that we will do as nurses. Whether it's nephrotic syndrome or congestive heart failure, we're always going to do those things. Now, acute glomerulonephritis is an acute thing that can become chronic, but this again is from a strep throat. So we know that we have rheumatic fever, right? Well, acute glomerulonephritis is the second thing because we didn't completely treat a strep throat. And it's usually within 3 weeks after they have it, we will see what goes on. What do we see with glomerulonephritis? We're going to stop urinating. So you're retaining fluids, you retain fluids, and blood pressures go really high. Also, you're going to see blood in the urine and protein in the urine. So how do we treat it? Well, we're going to treat the strep. We're going to give antibiotics for these children. Now, sometimes these children, they've gone on too long. We didn't catch them good enough. It will be more of a lifelong chronic condition, but most are an acute thing. So again, we're retaining fluid, we're not urinating. So what are we going to do? Exactly what I said before. Daily weights, I&O. We'll be measuring the belly because this is all about swelling and the kidneys. And of course, low sodium, watch the salt, fluid restriction. Wilms tumor. We've talked about it, a nephroblastoma. It's a kidney tumor, and this is usually boys, usually about ages 3 to 5, African American. And this is a tumor that's very fragile. So we don't touch the belly at all. I saw it one time. It was a kid, he was 3, from Haiti, right after the earthquake down there. One of the people found them from our hospital, and through a religious group, they got him up to us and came into my ER. And I was like, what's wrong? They said, we don't know. They just said to get the kid, bring him to you. I said, okay. The papers are all in French. So I did my assessment and I found this big round softball sized tumor in the left lower quadrant. And I knew what it was for some reason. So we don't do biopsies on this, okay? All we do is a little bit of chemo radiation maybe, and then they give a big incision because they don't want to manipulate it. And they have to go really down into the cavity, into the back where the kidneys are. So your incision is bigger and they take it out. These kids do well, and this kid went home, and actually the floor did receive a card from him a couple of months later that he was doing well. Kidney failure. Kids do have kidney failure. It could be acute, which could be due to that obstruction because your kidneys couldn't tolerate it, so they shut down. It could be due to some kidney disease, hereditary causes it too, for your chronic. I've actually seen acute renal failure due to ibuprofen. The kidneys completely shut down. So we have to look at the whole picture. If it's just happened, we got to find out the cause and we need to treat it. Now, in acute renal failure, your kidneys slowly stop to filter, you slowly stop to urinate, and then all of the conditions of renal failure start. You start that metabolic acidosis, problems with the potassium, problems with making red blood cells. I mean, this is all part of adult, same thing you see. And we know it will get worse and worse as time goes on. One of the big causes of acute renal failure is dehydration. So you see a kid who's dehydrated, and that's why we know vital signs. I want to know heart rate, blood pressure, skin turgor, urination, mucous membranes. What do these things look like? And if we see acute renal failure, we'll be quick to give boluses of fluid to get that body perfused again. So chronic is considered when 50% of the kidneys are gone. And then, of course, it continues to get progressively worse. A lot of these kids are on hemodialysis. Now, young infants can't be on hemodialysis, and we're going to go into what peritoneal dialysis is. So hold on for that. So what causes chronic renal failure? Well, if your kidneys don't connect to your bladder, there's no drainage, or reflux that's damaging it like crazy. At the hospital where I was working, I actually did some clinicals up there with some students. And it was the GU floor, and it had the dialysis room. And what they found is there was a lot of inter-family marriages that was causing it, marrying first and second cousins that they had seen. So I'm like, okay. And then, of course, lupus, attacks all organs, or if it's anything chronic, where your kidneys are chronically being infected. So how are we going to treat kidney failure? Well, chronic. They're going to be on some sort of dialysis. Again, fluid electrolytes. We're going to give that erythropoietin because of their red blood cells, just like we do adults. Kids get it too. And these kids, it's really hard for them to have a normal life because they're always hooked up to a machine, but try to make it as normal as we can. Now, I quickly mentioned peritoneal dialysis, and this is what it looks like. Now, when you're small, we can't put in a venous and arterial catheter to take blood out and put it through a machine and push it back in. That flow going in is too turbulent, and it will rush to the head and cause intraventricular hemorrhages. So it's non-conducive to newborns. And they're doing this a lot more with adults now. Instead of going right to hemodialysis, they're starting with peritoneal dialysis. And what they do is they put a catheter into the peritoneal cavity. And at night, there's a machine, there is liquids that the nephrologist orders. And what they do is they put in a certain amount of fluid. And it sits there for a certain amount of time. And then they drain it, and it goes into a Foley catheter bag. And it might be 8 or 10 cycles. That's what they call them, cycles, during the night. So the kid sleeps at night, the machine's going, and the kid has a normal daytime, okay? When we look at the urine output, it's the difference in the amount of fluid that went in to what is there when we're done. It could be 10 cycles of 100 mLs, that's 1,000 mLs, and the bag had 1,300 in it, urine output was 1,300. And then, of course, as they get older, they can tolerate the hemodialysis. So we warm this fluid. Now, this is the only place where we can do anything for the kidneys, is in this belly. We have to guard the sterility and keep it from being infected, because if that abdomen goes, there's nothing else. So we will, under sterile procedure, I'm talking hat, mask, gloves, gown at home. And it's just to clean off and hook up this tubing to put it in there. And it sits on this warming plate and it goes into the belly. Now, what do we need to monitor as a nurse? Well, pain in the belly would be a cause, or redness around the catheter we might see, but a change in the color of the drainage coming out, that is a cause to immediately call the doctor, and he needs to order an antibiotic. We need to protect that belly. You can see why. Usually it's done every night. They'll do this sort of thing, and that drains the urine for the day. So our biggest concern is infection, peritoneal dialysis. So what best describes acute glomerulonephritis?
B.
Yep, it's another strep infection. Very good, thanks. Okay, GI has a lot of conditions. They're very hard to keep track of. So let's see what we can do for you. Well, the GI tract is mouth to anus, and its basic function is to absorb food and to eliminate waste, right? That's GI tract. So there are reasons why we don't get everything we need. The vitamins, the minerals, they can't absorb it, whatever. We're going to look at some of those. And we know if we don't get nutrition, the cognitive growth, all of those things are going to have problems. We measure outcomes with height and weight, right? Are we getting enough nutrition? Always height and weight will do that. But if you have cancer, HIV, sickle cell, cystic fibrosis, you need pancreatase, right? We're not getting all of the fat vitamins. And of course, that young child, that premature, low birth weight child, we're going to have some problems with nutrition. Celiac disease. Celiac disease is that where they don't absorb the foods the way they should. And has to do with gluten. So these children are have to be on a special diet, because if they take foods that are not on their diet, their intestines get all inflamed, the cilia get inflamed, and the pain is intense. So the treatment for this is just diet. So what do we do? So when you're on a gluten-free diet, you have which sort of things that you avoid? Do you remember?
Breads.
Like rice,
Yeah,
oatmeal.
your wheat, your rye, your barley, yes. They can have rice, like rice bread, but the others, no. And can you imagine a kid can't eat a birthday cake at school? Because it has those flours in it. So it can be quite distressful. Now, the one thing that I've noticed on this diet, they can have eggs and bacon and milk and ice cream and fruits and vegetables. It's just that bread stuff they can't have, which means macaroni and cheeses, and they can't have baked potatoes and all of those things. But there are so many supplements today. So these kids are luckier today than they used to be. Food allergies. Well, we know infants aren't fed normal foods or introduced until 6 months old because their GI tract don't tolerate it to then. And we'll wait 4 to 7 days in between changing each food because we're looking for a food allergy. Most food allergies are subtle, and it could be a rash. It could be a good rash like this one, or it could just be in the folds of the arms and the knees and underneath the armpits, the neck, and that's all you'll see. And it is an intolerance. So we don't want to do that to these children's immune system. So we will not give that food again. Lactose intolerance, they're going to be having that vomiting and that diarrhea. So food allergies, again, can cause a problem with nutrition. We know that if a child is constantly spitting up, they're getting rid of their food, right? They don't have enough nutrition, cognition, growth, we're going to see that. It could be from that vomiting, diarrhea, even constipation can cause problem because then they have abdominal pain, could cause bleeding. We know jaundice, problems with the liver, can have problems with digestion and bile in the gallbladder. What if they can't eat or swallow? There's something called Pierre-Robin syndrome and DeGeorge, where these tiny little chins, and it's really hard for them to swallow. So how are we going to feed them? So all of these things can create it. And a kid who has a fever is not going to eat. I have a grandson with me right now. Mommy dropped them off on Saturday and Saturday night, 1015. The kid don't want to eat. And that's just typical. Fever, I'm not eating. What do? Get the fever down, and then they'll drink. As long as they drink, they're doing good. Now, I mentioned dehydration is a big thing. We need to make sure kids are well hydrated. We know if they have a fever, they're going to sweat, so they're going to lose that. Urinating, vomiting, diarrhea, and then, burns is another thing that can cause it. Hopefully, we don't have kids burning themselves. It happens, but hopefully not. So what do you see with dehydration? I love these pictures here, and I'm going to tell you why. This upper right picture, the kid is just sitting there, sitting up. That fontanelle is sunken. but look at the color of that child. They're pale. The nose is pale. The ears are pale. I bet if I listened to that heart rate, it's 200, easy. They're that dehydrated. You know, I'm going to look at their eyes will sunk in when you see kids this dehydrated. And of course, elevated heart rate, decreased blood pressure, prolonged capillary refill. They're not urinating. Any dehydrated patient will show these things. Infants that sunken fontanelle, and they're going to be crying, but there's no tears. You're like, oh my goodness, look at this baby. They're crying. There's no tears. This kid needs some fluid like now. So what's our number one thing that we want to look at? The metabolic profile. We need electrolytes. We want to see where we are to start. And we're going to have to give them fluid. Now, if a child is vomiting, we can't give fluids by mouth. They'll need IV. Usually diarrhea, they're not vomiting, so we can give electrolyte, PO electrolyte stuff. Be careful. Whenever we have a child who is this dehydrated due to vomiting, diarrhea, we cannot put an IV with potassium up until they void, or unless we get that lab value back to see where that potassium is, okay? Because it could be very elevated. Because remember, it can cause renal failure, right? Renal failure, elevated potassiums. So very, very careful with that. And of course, if they're vomiting, we'll give an antiemetic, you know, Dosteron, Zofran works great. And then we wait, and then little sips to start with. Measuring intake and output, you know, as I said, vomiting, urine, sweating, looking at the vital signs, heart rate, blood pressure, that skin turgor. And if they're in the hospital, we can monitor their weights every day. We could see, are they losing, are they gaining? And I absolutely love those fontanelles in infants. You could see it's, you know, the bulging or the sunken. And we know to look at that. And the color of these kids, you'll never forget it. If it's an older kid, they're not going to be as alert. You know, they don't have blood flow going to their brain, so they're going to be somewhere else and sleepy. Now, diarrhea is something that happens in children. It could be due to many different things. The most common cause of diarrhea is actually antibiotics. You give antibiotics to a children, they usually get diarrhea. So we need to treat diarrhea. So what do? Again, we're going to say they need fluids. And of course, we're going to check their electrolytes. Usually these children, unless they're very lethargic, will get oral rehydration with electrolytes, okay? But if they're very lethargic, IV fluids are quicker, we'll do it that way. And we feed these kids. If you don't feed diarrhea and only give liquids, what do you expect to come out the other end? Only liquid. So we need to tighten it up. And you know what the number one treatment they give for diarrhea in the hospital, a doctor's office, is some sort of probiotic, because we need to replace that flora. Now, I mentioned it quickly about constipation and urinary tract infections, okay? And it is very evident. You go into the nephrologist, urologist, and to talk about your child urinary tract infections, one of the first things he's going to ask is how many times a day does your kid stool and what does it look like? Because then he could tell if it's due to that. Now, children are very, they're unusual. They can actually, the only thing they can control in their body is their bowels. I have seen children hold their stool for 10 and 14 days, and the parents say they're eating normally. Usually, it's because they want attention. Whether something in their life is happening, mom and dad are arguing, maybe they split up, maybe the dog ran away, who knows? But you see that as a cause, some environmental something happened. So it is something that needs to be looked at when we're looking at with constipation, because we want to have that stool free flowing. Now, Newborns should have stool within one to 1.5 days, 24 to 36 hours. Now, if you do not see a stool, now this is a meconium stool. That's usually the first stool that we see. It's gooey and it's sticky just like it looks. If we don't see that, something's wrong. It could be intestinal atresia, which means there's something that's not connecting, okay? Stenosis, a narrowing somewhere in the intestinal tract. Hirschsprungs, we're going to go into. Hypothyroidism is one of the things that can cause constipation, and cystic fibrosis. So if we have a newborn not stooling, you'll see them doing a sweat test for CF. They'll be checking the thyroid hormones and doing an X-ray of their abdomen. Now, constipation during infancy, most breastfed infants have nice loose stools. Infants that have formula usually have more formed, harder stools. It's just what there is. So constipation, we treat it in many different ways. Sometimes physicians will say, even though they don't absorb it, maybe a thing of prunes, little apple juice, they'll tell you something very natural to do for the child, not medications. Peptic ulcer disease. Now, children do get ulcers. Children are little worriers. They worry in so many different ways. So how do we treat them? Well, just like adults, we give ranitidine, Zantac. And what does Zantac do? It reduces gastric acid production. And this is the first thing we do. Of course, if it's something with diet, we'll change the diet. And we could add on as many medications as they need, but usually they'll start with the Zantac, the Pepcid, and actually finding out why they're upset, why they're the little worry kids, can also help. There can be hepatic disorders. I mean, there's all sorts of hepatitis out there due to many different things. And it's an inflammation, whether acute or chronic, the liver. And we know that children with hepatitis have to have a special diet. Now, we know that the liver secretes bile, which has to do with fat digestion. So if you have an inflamed liver, you're not getting this produced. So how are you getting fat digested in your body? You're not. So what happens is you get gassy, pains, and it hurts, and distension in the belly. So people with hepatitis should be on high protein and high carbohydrate, okay? Because, and keep that caloric intake up, but low fat, so we prevent all of that bloating and gassing and flatus and all those things. Okay, Hirschsprungs. This is something usually found at birth due to no stool. Now, it's also called a congenital aganglionic megacolon. Oh boy, big words. What does that mean? Well, that big pouched out stretched area has no nerves in it. So there's no peristalsis. There's no feeling. They don't feel it being stretched. And if you look at that tiny little thing that comes down there that says rectum on the end, that's the only place where stuff can come out. So sometimes you might see a little bit of ribbon. It's like coming out of ice, you know, an icing, you ice a cake, just that little coming out. Well, that's what these stools might look like. So what do? We see these little ribbon stools. We feel the belly. We can feel it. We're going to do an X-ray. We see the X-ray. We see this outpatching going on. And they go in and do a biopsy, a rectal biopsy. And they find no nerves. So it's a two-part surgery. They have to go in, remove that part of the colon, and this child will have a colostomy. For usually within the first year, it will be closed back up and anastomosed, okay? But because of this, you know, they do get this colostomy. So again, a lot of teaching for parents on ostomy care, et cetera. acute appendicitis. Well, appendix, I think the most common ages for this is that school age. Just like adults, you're going to feel that right lower quadrant, McBurney point. These kids usually walk in holding their right lower quadrant bent over and limping on the right leg. And you're like, oop, that's an appendix. And we know if all of a sudden that pain disappears, that appendix probably has burst. So if it is an appendix, we get it before it bursts. These kids do great. They're usually home the next day, that quick. But if it bursts, that appendix has spewed toxins into the peritoneum, and huge infection of it goes on. Yeah, they wash it out and rinse it, but still, these children, that intestines is upset and it's angry. So nothing to eat or drink. To keep that intestines clean and from really working, they put an NG tube down. So even the gastric juices can't go into the intestines. So an NG tube to low intermittent suction is put on. These kids are on IV fluids and of course, IV antibiotics. We'll be monitoring their lab values. We want to make sure their electrolytes are okay with this suctioning going on. And we're going to be monitoring that white cells to see if it's coming down with those antibiotics. Remember, when they closed that wound for this surgery, there was an infection inside. So when they close it, the chance for it to be dehisced is greater than normal. So please look at that wound. And these kids can get up, they can get out of bed, they can ambulate. But don't ever make a kid get up and ambulate unless you medicate them first. This hurts, okay? And their abdomen is inflamed and it's tender. So make sure, give them something for pain and then help them get up, get out of bed and prevent all the complications. Intussusception. You know, I never knew what an intussusception was until I saw my first one. Usually this is your toddlers, 1 to 3 age, most of them, but it can be younger. The youngest I've ever saw was 5 months old. And the intestines scope into each other, just like a telescope, and it causes great pain. Usually by themselves, they come out by themselves. So what we do is we see what's going on, we get them to ultrasound, and if they're still in pain, we might see it there. Sometimes, though, it's already come out and the kid's running around fine. So we'll send them home, have some good fiber in the diet, and say if it gets worse, come back in. With this, because the way it pushes in the diaper, you'll see currant jelly stool, okay? That little globulous jelly, and you might see a little bit of blood streaks in it. Very specific to intussusception. This is severe pain. These kids, their legs, inconsolable. These kids are like, their legs are going, they're crying, they're bouncing, they hurt. When it pops out, they're fine. And usually just diet cures it. But sometimes it stays in there and it swells and they need to go to surgery. And they will take out some of the length of the intestines and put it back together. So it's a big surgery. So methyl diverticulum. Inside your small intestines are sometimes these little out patches called a diverticulum. But inside this little out patch is a blood vessel. And sometimes they rip or get ulcerated. And you will see painless rectal bleeding. You might have some tenderness in the abdomen, but you'll see red blood in the stool. So you know something's going on. So what they do for this, they go in, they're going to do this radionuclide study where they find where the bleeding is, and they got to do surgery and take that diverticulum out, and they need to cauterize that blood vessel there. These kids do really well once we figure it out and where it's at. IBS, ulcerative colitis, Crohn's. IBS is mouth to anus. anywhere inflamed. Ulcerative colitis is going to be, segments that get inflamed. How do we treat this? Well, usually it's just medical, steroids, anti-inflammatory, and diet, making sure they're on a proper diet, keep that belly from being inflamed and keeping their stools moving. These kids can live a normal life as long as they're doing all the things they need to do. And of course, during stressful times, that's when you see them start to react. Short bowel syndrome is usually due to a child is born and something happens called necrotizing enterocolitis. So when infants are born, we feed them. And sometimes the intestines aren't ready. Maybe it was a hypoxia episode and this piece of intestines wasn't ready to accept food and it dies. And it could be a small segment or a large segment. The biggest one I've ever seen, which ended up in a short bowel syndrome, was my little Jessica. Jessica was a triplet, and she was the one of them who had a cardiac condition. Post-operatively, her second stage surgery, her belly blew up, and then she was getting a little bit of feed down a tube called a nasoduodenal tube, just a little bit to keep her gut moving. Her gut wasn't happy. They had to remove 58 centimeters of her small intestines. So where is she absorbing food? There was like hardly any left. So this kid needed extra special attention to nutrition. So what they did, they put a G-tube in, gave her feedings. Now, of course, they'd allow her to eat by mouth if she wanted. And then she had in a central line, and she would get hyper-AL and lipids at night. So she was getting maximum nutrition she possibly could. Now, this kid today is, I think, 19 years old when I saw her last time. And she was eating by mouth. She was skinny, but she was doing really, really well. Gastroschisis is when the stomach is born on the outside of the abdomen. The belly tried to close, but the stomach was outside. And our concern on a child born like that is your insides are on the outside. Infection control, keeping it in a sterile dressing, and then surgery comes in and tucks it in little by little, eventually gets it in, goes to surgery about a week later, and they close it up. The inside still work, but it was born on the outside. This can happen with bladder too, the urinary bladder. Same thing, worry about infection control when the insides are on the outside. Hernias, we've seen umbilical hernias, inguinal hernias. Again, these are benign if they're soft and you can push them in and out and they're non-tender. If they become hard, tender, this is a danger of incarceration or strangulation, needs surgery. Because if not, it's twisted, it's not getting blood, and the intestines will die. So this child, if we were at a doctor's office, we'd say nothing to eat or drink, get to the ER now, and we would be doing, X-ray, CAT scan, ultrasound, whatever they needed, and they'd be sent to surgery. Another hernia they have is when the diaphragm doesn't completely go between the chest and the abdomen, and the abdominal contents go up into the chest. And it's usually the left lung is not formed because of all this. These children come out and are very sick because they only have one lung and that's pushed over to the side. So you have minimal space to oxygenate. Very, very sick kids. They usually do this surgery at bedside because they can't move them, okay? They're usually on ECMO or very high level ventilators. These kids today do okay, but for life, one lung. There's other things in the intestines, malrotation, Sometimes it goes and knots over a artery, which causes lack of blood flow and pain. Sometimes it's in a knot, the way that they're formed. Again, no blood supply, and they can burst if you can't get contents down. So when we're looking about an abdomen, we're starting to see a fever, a distension, we're going to be looking for that, and it needs surgery. Sometimes infants are born without an anus, and it's called an imperforated anus. And there's a picture of one there. Now, you have been told in OB, the first thing you do with an infant is do a rectal temperature because you want to check their temperature accurately, right? Well, they're making you check the anus. Is there one? Now, remember, your mouth and everything's still producing liquids. So it is an emergency. This child needs to have an ostomy made. So where does those, contents from the GI tract go? Sometimes you have fistulas between the vagina and the rectum, or you might see the bladder to the rectum. If you're seeing wrong stuff coming out of the wrong body part, it needs to be investigated. I've seen stool coming out urine, the urine tract. So this can happen, and it can boys or girls, doesn't matter. Vomiting, one of the most common things we see in infants, right? They do vomit. It could be just a dribble or it could be across the room. And that is a different case. But if a child is vomiting, remember, we need to teach them, parents, how to burp children, how to have them sitting up after they eat, and not overfeeding. Have them tell us, how much do you think? What is the color of it? Okay. And then, of course, if they're vomiting a lot, we're always going to be looking for signs of dehydration, which is elevated heart rate, decreased blood pressure, not urinating, refill is prolonged. And again, we're going to be given an IV bolus of only saline. We never ever bolus dextrose, and we never add potassium until they urinate or until we have a lab value. So the first thing is nothing to eat or drink until we determine what's going on. And children love to eat a lot of good stuff. I think the most common of things that children like are their vitamins and Tylenol or Motrin, those crunchy ones that taste good. And the thing with this is some of them are benign and some of them aren't. I've seen kids eat rat poison, and then you worry about coagulopathy issues. And this kid will be put in the ICU, and we'll be monitoring blood PTTs on these kids. Vitamins that they eat without iron, actually it's just will come out. And it's actually all right. With iron, it could be too high, the iron level. So it could be iron chelation that happen. Eating lead paints, on the windowsills, chewing on them. Kids put everything in their mouth. They chew. If it's an older home, they can get that paint, and it could be that. So again, looking for this thing, giving parents poison control number, very important. Esophageal reflux. Now, children, infants can have reflux, okay, that vomiting. So I've already told you what to do for that. What if you're an older kid and you're always, how do you know it's reflux? Well, usually older kids will have this chronic cough, and they're going to be complaining of heartburn. And that's because it's going up and down their esophagus, and it's really causing a lot of pain. How do we treat it? Well, we start with the Pepcid, Zantac, one of those, and then we'll add on any single meds that they can. And that would be the medical treatment. Now, sometimes, no matter what you do, they're constantly refluxing. And now the esophagus is getting really irritated, and you're having all this aspiration pneumonia going on. So they'll do something called a Nissen fundoplication. They also do this procedure when you put in a gastrostomy tube to prevent the feeding from going up. and having aspiration. And all they do is they take the stomach and put it over the esophagus so it can't go back up there. And it's called a Nissan fundoplication. Now, I told you there was a different sort of vomiting. It's a vomiting. It's called a hypertrophic pyloric stenosis. Well, where is the pyloric valve? It's at the end of the stomach before it goes to the small intestines. And it gets thickened and it's narrowed and fluid, food, milk can't get down. These are your young children, usually somewhere between 2 to 3 weeks up to 2-3 months. And how do you know the difference between the vomiting? Which one is more emergency? Well, hypertrophic pyloric stenosis, they're not getting fed. They drink, the food goes down, minimal gets to the body. But all of a sudden, this is the exorcist. Across the room, forceful vomiting, as in be careful, your feet are going to be splattered 10 feet away. Easy. I mean, it is very significant. It's because they fill up and then they vomit. And then the kid starts crying because they're hungry, because they've lost all their food. So you feed them again, they're going to vomit again. So the first thing we do is say, please, no more feeding your child. It's going nowhere. Now, when I get a kid in who the parents say they're vomiting, I'll say, does it dribble or does it go across the room? If it's across the room, I'm going to take my hand and put it right underneath the breastbone. And you're going to feel, and you feel it. It's like a marble, like an olive. It's like that thickened material on the pyloric sphincter. And you can actually feel it there. And you're like, this is pyloric stenosis. How do we treat this? Well, a kid, number one, nothing to eat or drink. And we're going to be giving IV fluids to give them the fluids they need. They go to surgery. They open up that thickened valve. And these kids, the next day, are going to be getting clear liquids. And usually they go home within 2 days. Usually there is no other issues with it. So pyloric stenosis is forceful vomiting. Now, GI has to do with mouth, right? Mouth to anus. There are children who are born with a cleft lip, cleft palate, or just cleft palate. Usually, if it has the lip, can you imagine trying to suck on a breast or a bottle without a lip? So our issues are feeding, nutrition. So within the first 2 to 3 months, they like to close the lip to at least give them a seal. And then they put this thing called a Logan bow here. So if they're moving and swishing their face into the bed or wherever, it's not going to rip it apart because it's a plastic closure. These are all the type of things, one side, two sides, with the palate, without the palate. I've seen just the palate. So the palate is closed between 6 to 12 months old. Now, the palate, if we don't repair it that early, this kid's going to have a hard time pronunciating words. You don't talk like that because you cannot pronounce it. So this is all about speech, and we want them to be able to speak well, so they will fix it. Now, you see that beautiful bottle there? This was made by a mother of a child that had a cleft lip and palate. And that top is soft, very soft. And you hold it over and the milk goes down. And slowly when the kid sucks, you squeeze it a little bit. So the kid is getting milk, getting satisfied as they eat. And they're sort of getting that pleasure of sucking. Because remember, self-soothing is sucking, right? So they get it like that. Sometimes they've got these crazy breastfeed things they can put on, but you know, to breastfeed a kid with a cleft lip palate is very difficult. So, I mean, if a parent wants to try, absolutely. But again, we're going to worry about aspiration. Now, another thing that can happen at birth is when the esophagus does not connect to the stomach, called esophageal atresia, or the trachea and the esophagus are connected by a fistula. So if I ate anything, where's the food going to go? In the lungs. It's the only place it could go. It can't go in the stomach. There's a fistula, it's going to go right in the lungs. And now I have aspiration pneumonia. So what do you see? What would this kid look like? Well, at birth, they're trying to swallow, they can't. So they're gagging, they're coughing, they're spitting, they've got mucus in their mouth. So how are we going to treat these kids at birth? Because you can't do surgical repair immediately. You've got to now say, okay, what do I have to do? Well, head of the bed elevated. We're going to have suction at the bedside and suction. Nothing to eat or drink because it can't get in there. Putting nothing, not even wetting the mouth, because it doesn't go anywhere but in the lungs. We want to prevent aspiration. So keep that airway open. Keep that prevention of pneumonia by keeping the mouth clean and nothing by mouth. And then what they do is they put these kids on IV fluids. And because even their mouth has mucus and they're going to choke on some of their own mucus and it's going to be aspirated in their lungs, they're going to be on antibiotics just because of that prevention. I've seen kids have this done. They're normal kids. It's just the things didn't connect right. And they can have a normal, healthy life once it's reconnected. So a lot of stuff in GI/GU you don't see in the adult world. Any questions? All right, who wants to win a Kahoot? Savannah, it's your day. You gonna win? All right. How about you, Kriana? Esther's gonna go for it. I know that. And Nikki, Sydney. Oh, Kelly's here. Oh, Ashley. Here we go. Da, 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 da. There we go. No, I can't cover everything in lectures, so this Kahoot says concepts you need to know. Again, as I told you, I have re-updated it. Remember, some of you are sending me right now, you know, what diagnosis you'd like to do for pediatric assessment, please let me know. And there are a lot of things due this week, so try to keep caught up with it. All right, let's get going. GI/GU. I'll multi-select. All of the following are symptoms of dehydration in an infant, except, right? So which ones are? Dry, pale skin, elasticity's gone, weak, lethargic, heart rate up, blood pressure down, prolonged capillary refill, and a decrease in urine output, not increase. Make sure you read the questions good. That's what some of the test questions, reading it well would have been a better answer for you. What is the priority treatment for a child with dehydration due to profuse vomiting? So if you are vomiting, you can't give anything oral. They'll just vomit. So it is IV fluids. You will see vomiting is usually IV fluids. Diarrhea usually will be oral electrolytes by mouth. What is a treatment for an infant with diarrhea lasting for 4 days? So diarrhea, we're going to feed them. Okay? Diarrhea, we feed them. And then as we're taking it, they're tolerating those liquids. Then we're going to introduce food because we want to put some content into that stool. What acid-base imbalance might you see with a child that's having profuse diarrhea? Like I said, I'm going to hit you with ABG type questions because I believe there was 4 on the last essay. So what do you lose when you're having diarrhea? So when you are having diarrhea, you're losing alkaline because that's all of the digestive material is alkaline. So that's metabolic acidosis. Now, if you're vomiting, you're losing gastric acid. So you would be in metabolic alkalosis, okay? Think about that. They're different. When you're diarrhea, you're losing alkaline. If you're having vomiting, you're losing acid. So you'll be the opposite of what that is. A multi-select. An infant is not past meconian stool in the first 24 to 36 hours. What would you assess for? So we're going to have hypothyroidism, cystic fibrosis, and Hirschsprung's disease. Will we see an electrolyte imbalance if they're not stooled? It really doesn't correlate. I mean, would we check it anyway? Yeah, but the things that we're looking for are the other 3. Deficiency of vitamin D causes. So vitamin D causes rickets. Vitamin C is scurvy, okay? Knowing what the deficiencies are will give you the name. I'll multi-select. What treatment can the nurse anticipate to a child unable to eat or drink anything with profuse vomiting and diarrhea? So we want IV fluids for sure. They're unable to eat or drink, but we want to know where those electrolytes are. So those 2 go hand in hand. You start an IV, you're going to pull labs. You're going to pull that basic metabolic profile, which looks at electrolytes. Another multi-select. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember that appendix is full of all of this caustic material. And the intestines are angry now. So complete bed rest? Absolutely not. We want them up and out of bed for sure. IV antibiotics is, of course, your priority. And we're going to have an NG tube to keep the intestines empty because it's angry because of all that material that's been all over it. And then because it was dirty inside, we want to make sure that that wound does not dehisce because it wasn't two clean places put together. So the chance of dehisce is big on these ruptures. Passage of urine, usually at night, in children who should have voluntary bladder control is caused. What is it called? And it's called enuresis. Now, let me explain epispadias and hypospadias. In a male, urine's supposed to come out the end of the penis. In epispadias, the hole is on top. It doesn't come out the end, it's on top. Hypospadias, it comes out the bottom, anywhere on the bottom. Here, doesn't matter, anywhere on top. These will be repaired. Now, the thing with this epispadias, hypospadias, they need the foreskin to use as a cover, as a plastic closure after surgery. And it covers it, so they can't be circumcised. Think of the Jewish faith. They like a brisk, right? They can't do it. We need that piece of foreskin. After surgery, they put in a catheter that holds open that, the meatus, keep it open. And then it's just a stint that we just keep in the bladder, in the diaper. It just urinates, and about a week, 10 days later, the urologist will remove it. But these kids do well besides that. And they do urinate normally. It's just that was born with a hole in the wrong place. We know vesicular ureter reflux is when it goes the vesicle, bladder, up into the ureters. A multi-select. What is Hirschsprung's disease? Remember, Hirschsprung's is a two-portion type of deal. It's going to end up with a colostomy, and then they're going to reanastomose within the first year. It's congenital absence of that parasympathetic ganglion, which is basically no nerves. And the other name they call it is congenital aganglionic megacolon. There's no nerves, there's no peristalsis. It stretches, it sits there, and it could burst if it got too big. So it has to be removed. A multi-select. When teaching parents about Hirschsprung's disease, a nurse would include so it causes that bowel obstruction. Yes, it does. It is a two-stage surgery, the colostomy and then the closure, and then monitoring those bowel habits. Very, very important. We do not give laxative and enemas to infants for this. It's a surgical repair. What types of stools would an infant with Hirschsprung's disease have? There's a big outpatching, and there's a tiny little area where it goes, to the rectum. And it's called ribbon shape. Think about putting icing on a cake. It's a tiny little thing trying to get through. It's like a ribbon, if you see that. Which is a condition that occurs mainly in children when the intestines telescope into itself. It telescopes, and it could spontaneously come out. Sometimes it doesn't, and it will need surgery. And it's called intussusception. Yes. Current jelly stools, right? This diaper is current jelly stools. Gastroesophageal reflux disease, GERD. What's that? So reflux is when it goes from the stomach and goes up the esophagus. And we know our biggest concern is aspiration, and that esophagus is getting irritated with all that gastric acid. Inflammatory bowel disease includes what? IBS is what? And how do we treat it? Diet and steroids if it's too inflamed, right? And it's anything, any part of the intestines is considered inflammatory bowel disease. We call it mouth to anus. What would the nurse be looking for when a patient has Meckel diverticulum? Remember that diverticulum, that thing that sticks out and it gets hooked and it rips in the small intestines? And it is painless rectal bleeding. You might have some abdominal tenderness with it, but it's painless rectal bleeding. You're bleeding and you don't even know you are. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? What are you going to ask this child, this parent? What is most important? Tell me where that pain is. What is it like? Is it something like an appendix, which needs surgery? Is it something like maybe an IBS, ulcerative colitis? I want to know, where is it? What does it feel like? And then I can make my treatment plan according to that. What would the nurse expect to see in an infant with biliary atresia? So this is the tube that connects the liver into the common bile duct. And if you have an atresia, there's no opening. A is without. So you're not getting bile down into the small intestines for ingestion. So the stool color would change. It's going to be clay colored. And remember, the belly is going to blow up. No fat digestion is going on. So those are the two things. And of course, they're going to turn yellow eventually, because you have to get rid of that, somehow get it connected. And that's what they do. They go to surgery and try to reconnect to the small intestines, to the common bile duct. What structure of the mouth can be impacted by a cleft lip and palate? And when do we do the surgery? What are we concerned about with cleft lip palate? And I think it's nutrition, and even having them suck, because that's what kids like to do. Hard palate, lip, soft palate, either one or all of them. Cleft lip repair is typically done when? When do we do the lip? You remember, it's important to be able to put that mouth around a bottle, and that's that self-soothing. And it's between 2 to 3 months. We do that first. When does a cleft palate repair typically occur? And remember, we try to do it so that we don't affect speech, because if you don't take care of it, you know, I've seen adults that just don't talk correctly because of the palate, the way it wasn't repaired, and they'll talk more like nasally. That's just part of what you hear. And it's 6 to 12 months we do that one. Esophageal atresia. Remember, A is without. Osis is an opening, narrowing. So esophageal atresia means the esophagus is not connected anywhere, doesn't go to the stomach. So treatment, nothing by mouth, because it's just going to go into the lungs. And now we're going to have aspiration. What are the classic signs of esophageal atresia and tracheoesophageal fistula? No opening to the stomach and a connection between the trachea and the esophagus. What do you see? We are going to see that cyanosis, the coughing and the choking. Now, olive-shaped mass, that's pyloric stenosis. Current jelly stools, that's intussusception. Bilious eminence, that is just a part of a vomiting, and that would just be the color. It's not to a condition. A multi-select. A neonate with suspected tracheoesophageal fistula, nursing care should include what? Well, you need to know tracheoesophageal fistula. What is it? What are we concerned about? What are we trying to prevent? So we're going to elevate the head of the bed. Nothing by mouth, guys, nothing. It's going to go directly in the lungs. And because it goes in the lungs, IV fluids and antibiotics. Those are the things that we do for tracheoesophageal fistula. It's also called a TEF. A 5-year-old child's complaining of epigastric pain and a persistent cough. What would you suggest? Even heartburn they'd feel. This is probably GERD. This is reflux. How do we treat it? Well, all the meds that we would give an adult, you know, start out with the Pepcid, ranitidine, and work up. And all of them, they could put them on. Of course, changing diet. And then, if they need to, surgical, the Nissen fundoplication. What is ranitidine used in a child with a peptic ulcer disease? What's the use? Why? It reduces that gastric acid production. So if you don't have extra acid, it's not burning the stomach, and it's going to be helping to heal that peptic ulcer. Less acid, it can heal. Signs and symptoms of hypertrophic pyloric stenosis. So hypertrophic pyloric stenosis is projectile vomiting, and then you put your hand underneath, right below that breastbone, and you will feel that marble, that olive size mass there, and then you know it is. Signs and symptoms of hypertrophic pyloric stenosis. What else? So there's going to be projectile vomiting. Now, they have a good appetite. They eat. And actually, as soon as they vomit, they want to eat again. They're insatiable. They can't get enough. So it is not a poor appetite. It's projectile vomiting. And be careful, it will come across the room. Preoperative treatment of pyloric stenosis includes what? So remember, it doesn't matter how many times they eat, they're going to vomit. So if we continue to let them eat, they could aspirate. So NPO immediately, start out IV fluids, so at least they're getting a little bit of sugar water before they go to surgery. And that's the treatment. What does a celiac disease affect? Remember, celiac disease is all about nutrition. It's all about the little villi and the small intestines that gets irritated with gluten, and it's small intestines. All nutrition you think is small intestines, okay? The large just absorbs all of, the other stuff, but the small intestines has to do with nutrition, getting it ready for the body. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, barley, which is basically your flours. They can have rice. Rice is okay, but wheat, rye, and barley, no. There's, even if you go into the bakery, go look, you'll see gluten-free products all over the place now today. And I think that's absolutely great. I'll multi-select. Vitamins that children with celiac disease are prone to lose are and this is all your fat, A, D, and K. C is water soluble and easily digested. The others, they have a hard time with, and many times they do need replacements. What foods would you select for a child with celiac disease? So as I said, dairy, eggs, fruit, vegetables are all good. French toast is bread. Macaroni and cheese is, the flours. And then of course, garlic bread again is bread. No, those things, no. Phimosis. This is a male. This is a child, a boy. Something happens. And actually, it was my grandson. So at birth, the skin that covers the penis is so tight, and you can't even pull it down in order to clean all that schmegma out. It's so tight that the chances of increased chances of urinary tract infections are there. My grandson was so tight, I could not, and I tried hard. I could not get it down. So they did have to circumcise him to prevent that. It happens sometimes, not all the time, but it does need to be pulled down. If you can't, it needs to be treated. It's called phimosis. What is a hydrocele? This is usually evidence where you have a kid who's, potty trained becomes incontinent, is where I usually see this come from, even adults. And what they usually do is give some antibiotics for this, or at least a shot of Rocephin. And it's literally just fluids in the testicles, and it causes some pain down there. And then, of course, that incontinence that you might see. Even in an adult, I have seen that. And antibiotics are the treatment, because that's not normal to be there, and it irritates. What is cryptorchidism? Again, another condition that I'm putting this concept in here. What is it? So you have two testicles in little boys when they're born, and that's why the pediatrician checks for them on the first visit. And if they're not down, they will continue to check for them. Cryptorchidism is when the testicles stool up into the abdominal cavity. Now, it has to come down because the testicles don't like that warm environment. So if we don't get it down, it's going to cause that testicle not to be able to produce sperm. Now, the trick on checking for this is make sure the room that you're checking is warm, because then they'll come down. If it's cold, they tend to suck up. So having a nice warm room helps. You suspect an infant with cryptorchidism. How would you examine the infant? So again, have them in a warm room, because we know if it's cold, they get sucked up. If it's warm, at least we'll try to get them down, and a question I would ask if I couldn't find one, this visit, have you ever felt it before? Maybe it's just, sticking up there. Very important that parents know, yes, I felt both. A hypospadias is what? So hypospadias is the opening on the bottom side of the penis. Epispadias is on top. Ventral, dorsal. A multi-select. How is the hypospadias corrected? So they used a foreskin. It's like that plastic closure, and they put in a stent. This is done under general anesthesia. They've got to splay open the penis. They've got to cut it up, reattach it. It is a big surgery. So it is general. Again, that stent's placed in there, and we do nothing. We just keep it inside a diaper to measure urinary output. And they take it out 7 to 10 days after surgery. But the foreskin is most important. And the one thing is, there are religions that there is this big thing about, circumcision, especially the Jewish faith. So something that they have to understand they cannot do. What is bladder exstrophy? I taught gastroschisis and bladder exstrophy. So the midline doesn't close, the bladder's on the outside. It still works. It works perfectly. And it happens, inter utero. And our job as nurses to keep a sterile dressing on it, prevent infection. But we're going to measure the diaper for urine. It doesn't do anything to that. It's just in the wrong place. What is the priority nursing care for an infant with bladder exstrophy? And yeah, that tissue integrity, we want to make sure we keep it good and keep it from being infected. Yes. And again, they'll make room and slowly they'll put it in and they'll close it up and it will be okay. What are the clinical manifestations of nephrotic syndrome? So we know nephrotic syndrome has nothing to do with renal failure. Your kidneys work, but it doesn't like protein and just gets rid of it. So hypoalbuminemia in the blood, protein, albumin is gone. And of course, then it spews fluid interstitially. So you have all this peripheral edema. You see it a lot around the eyes. And of course, low serum albumin, which is hypoalbuminemia. Good. Children with nephrotic syndrome are often given what medications for fluid overload? Well, think about nephrotic syndrome. There's a lot of interstitial fluid going on here. We need to pull that out to get rid of that edema. So we do it a little differently here. We've got to replace the protein, the albumin, by giving albumin, put it intravascularly, then give them some Lasix, which now is going to get rid of the fluid. But you got to suck it out interstitially, and that's what albumin does, and then follow it with the diuretic, and then we get rid of all of that peripheral edema. Okay? How would we know that medicine worked? We see increased urine output, right? What is used to treat nephrotic syndrome in children? And we give prednisone for it. Of course, other things we're going to do is fluid restriction, watch the salt, daily weights, intake, output, NSAIDs, no, antibiotics, no. We're going to monitor for infection and be careful with it. And we're not going to just monitor those things. It's many other things, but prednisone is the treatment. A child's admitted for acute glomerulonephritis. What recent illness could validate this finding? So rheumatic fever, glomerulonephritis, both. If they've had this pharyngitis, strep throat, that's what causes acute glomerulonephritis and rheumatic fever. So strep throat needs to be treated completely, and it's part of our teaching. We should tell them, finish the antibiotics. What is the priority nursing care of a child with nephrotic syndrome? I've said it about 3 times already, maybe 4. Daily weights, intake, output. And we're going to decrease salt intake, and we're going to monitor fluid intake. We're going to decrease that too. Blood sugars have nothing, ambulate, nothing, but it's weights, daily weights are going to tell us fluid balance. Why is erythropoietin used in chronic kidney failure? And this doesn't matter adult or children. So it increases red blood cell production and it keeps hemoglobin hematocrit high. I'll multi-select. Your children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Well, what is osteodystrophy? Well, when you see osteo, we know it has to do with bones. And dystrophy means there's something not right there. And what happens with chronic kidney disease, they don't have enough vitamin D and the things that bones need in order to, and calcium to grow properly. So what do you see? You see skeletal abnormalities. They're not going to grow the way they should. And then you're going to see high parathyroid levels, increased calcium, right? Parathyroid is calcium. A diagnostic finding of acute glomerulonephritis may be what? Let's see how many of you know this lab test. When we want to see if there's strep in the body, we do an ASO titer, which is an anti-streptolysin. So it is looking to see if there's strep in the blood. We know if it's there, that was the cause of the acute glomerulonephritis. So ASO titer is what you might find. You'll see that in med-surg too. That's a great test that's used to diagnose that. Which complication of peritoneal dialysis is most important? Something you're really going to be looking for. So we're worried about that infection in that peritoneal cavity, because once you have an infection there and you can't use it, there's nothing to work for the kidneys. So it is imperative that we're monitoring that very closely. And a change in the color of what's coming out could be your only clue. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? Now, I had this kid, I think it was 8 or 9, was playing hide and go seek, one of those things. And he was running in the backyard and went backwards into a trailer hitch. And he had this huge bruise over the kidney area. I'm talking, the whole side of his back. And he came in because the bruise was big. Now, whenever you're talking kidney, you're talking trauma, you always think potassium. His potassium was, I think, 7.4, 7.6. It was way up there. So he had really hurt his kidney. So it needed to be monitored. Did he fracture it? And actually, this kid did. I'll multi-select. What should the nurse anticipate for a child who just had a renal biopsy? Remember I told you it's very similar to a cardiac cath. But you're working with the kidney. So we're going to be monitoring intake output. We're going to monitor the dressing for urine or blood. We're going to be monitoring the abdomen for distension, and they're on bed rest 24 hours. Their bed can be up, pressure dressing, maybe even a sandbag on it, but very similar to your cardiac cath for this. They're not out of bed. till the next day, minimum. What would you do if the fluid draining from peritoneal dialysis has changed color and is now cloudy? We're going to call the doctor. What are we going to anticipate his order? Antibiotics. And that becomes your priority to get that into that kid as soon as we can. Good. Last question. What would the nurse provide to an infant that cannot eat normally? They're NPO, they can't eat. Remember, they take care of their stress and they're calmer when they have that non-nutritive sucking. We don't do anything vigorous mouth care or putting water, because sometimes that could cause aspiration. So if they cannot eat, giving them that pacifier really helps them. Number 3, Ashley G, you did it. Whoop, whoop. Number 2, M. Okay, M. Number 1, an SJR. Kelly and KV, good job, guys. What I want you to do is sign your attendance attestations. I want to wish you a happy Thanksgiving. I hope that you have at least a calm moment with your friends and family. And if you need anything, let me know. If you could get your pediatric assessments in early, I'll look at them, send them back for corrections so you can get the best grade you possibly can, okay?
Thank you.
Thanks, Professor.
Thank
Double,
you.
double, double, double.
Bye.
Thank you.
Thank you for everything. I hope you have a happy Thanksgiving.
I'm cooking. Thank you so much. I love cooking. It's good.